Good evening, all. Welcome to Mahamana Case Discussion Series. As always, we'll begin our talk session by an invited talk by Dr. Anuja Deshmukh. She is Professor, Head and Neck Surgical Oncology, TMH Mumbai, and she will be giving a talk on natural history of progression of upper alveolus cancers and maxillectomy defects. Welcome, ma'am.
Yeah, thank you. Thank you very much. And thank you, Asim and the team for inviting me here for such a wonderful talk. And it's a great honor to be here to be part of this program. Coming to the topic, what topic I have today to discuss with you is the natural history of progression of upper alveolus cancer and the maxillary defect. I'm not going to discuss the usual way of what are the types of maxillectomy and things like that, how to do the surgery, what should be the margins, but I'm going to deal with something, the unusual thing and unusual points we are going to discuss today regarding the this uncommon cancers in oral cavity cancers. So coming to the upper alveolus alveolar cancer, it is a very common presentation in Tata Hospital. But if you see otherwise in a population, the cancer wise, it is a very uncommon cancer among the other cancers. So it basically the upper alveolus, which is the ISD code 10, which is the one which we are going to deal with today. So upper alveolus cancer is uncommon and the common histology is the squamous cell carcinoma. And if you see the incident reported can vary from 3.5% to 22% over a period of time, like a 20 years, 10 years, like that. It needs to be differentiated from the other lesions from the maxillary lesion. It has got a close proximity of this site. It makes it difficult to localize the exact epicenter of this disease if the multiple adjacent sites are involved. So the imaging takes a precedent and then you can decide what is the epicenter of the disease. Erroneously, they can group together with the maxillary carcinoma as erosion of floor of maxillary antrum is the common scenario which you see it in a maxillary cancer. However, if you have a floor of maxillary origin tumor, they spread along the palatal canals and rather they go through the alveolar process of the superior sulcus. This point needs to be remembered. So coming to the prognosis of this upper alveolus cancer, it is different from the maxillary cancer and it behaves similar to the hard palate cancer. Also, the prognosis and treatment is different from the lower alveolus cancer. Upper alveolus cancer is more aggressive than the lower alveolus lesions and they have a poor prognosis as presentation is usually advanced stage and there is an early invasion of the infratemporal fossa, and which can be seen around 1/10 of the patients or a 50% of the patient also. It depends on which series you are looking at. So coming to the upper alveolus cancer, there is a thin layer of mucosa over it and the cancer can readily invade the maxillary antrum or the floor of the nose. The common symptoms are alveolar growths and the trismus. And it is usually inaccessible to proper evaluation if it is situated on the last molars area. So more than 50% of the patient, they present as a locally advanced maxillary cancers, the upper alveolus cancers, because of their late presentation to the clinics. And these advanced upper alveolus cancer progress to the surrounding structures like nasal cavity, paranasal sinuses, orbit, and the skull base, the surrounding cheek area, the palate, and through and through. So 21% of this patient may present with the cervical cancers, cervical metastasis as a late presentation. Versus if you look at the lower alveolus lesion, you will have a initial presentation only as a cervical metastasis that is seen about a 0.5% of the patient. So in overall, if you see 26% of the patient will have a cervical metastasis. They will have a multiple level involvements in about a 50%, 55% of the patient versus only 1/3 may have a multiple levels involvement with the lower alveolus. So if you look at our hospital database, which is a very old database where it has shown that upper alveolus cancer, if you do a surgery followed by adjuvant treatment, these are the best treatment modalities than only treating with the radiotherapy alone. So coming to the lymphatics of the buccal cancers, that is the maxillary alveolus, it drains to the submental area and the submandibular node area. The lymphatics of the lingual aspect of the maxillary alveolus drains to the superiorly, the deep jugular and the retropharyngeal nodes. If you read the Tiwari's paper, they also mention about the parapharyngeal and nasolabial lymph nodes involvement because of the upper alveolus involvement. So coming to the overall cervical metastasis is 35% because of the upper alveolus, and it goes to the submandibular gland. And as I said earlier, there are multiple levels are involved. Coming to the data, which I have told already about the Tata data, apart from that, there is another data where 25-year period where it has shown it is about 60%, 5-year disease-free survival. So coming to the upper alveolus cancer, if the most important thing is the progression of this upper alveolus cancer. If you look at this diagram, the picture, the superiorly it goes into the upper alveolar bone, the palate and the maxillary antrum. And you can make out this patient will have a loosening of the teeth if you have a superior extent of this disease. If this disease comes anteriorly, and then it may involve the anterior maxillary wall and the skin area. It may go medially as it reaches the superior part into the nasal cavity or the ethmoids. And laterally, it may go into the buccal mucosa, infratemporal, and the pterygomaxillary fossa along with the V2. If it goes through the maxilla, through the maxilla, it can reach to orbit, optic nerve, that is the mid structure, or a nasolacrimal duct, that is the medial structure. The most medial and superiorly will be cribriform plate, the frontal sinuses, sphenoid posteriorly, the ethmoids, and the nasopharynx. And via various fissures and the foramen, it can reach to middle cranial fossa through foramen rotundum, median canal, palatine canal, and the spinopalatine foramen. So you can have a florid kind of a disease which starts in the lower upper alveolus, goes into the maxilla, and can have a extension into the various structures which are in a proximity. So coming to the classification of this sinus carcinoma, we all have learned these two parallel lines which divides the maxilla into suprastructures, mesostructures, and infrastructures. And we know these two parallel lines which goes through the floor of the orbit, the bottom through the floor of the entry. The Ladderman has further added two more vertical lines which are going through the medial canthus area between that, and it divides the further it divides the ethmoids and the nasal fossa, apart from the suprastructure, mesostructure, and the infrastructures. If you all have learned our maxillas with the Ondrin line, just to revisit, that line comes from the middle canthus of the eye to the angle of the mandible, and the further vertical line is passed through the center of the orbit on the frontal section and divides into the medial and the lateral segment. This is the plane of malignancy. So anything which is a posterior superior sector, which is considered as the worst kind of a prognosis, and whatever is the medial and which is the antero-inferior sector, which is considering the medial, the nasal fossa is considered as a better prognosis. So we all know this classification and different lines about the sinus carcinoma and their its extensions. So what is the inoperability in maxillary lesions? So mainly the skull base involvement with the intracranial involvement, extension to the nasopharynx, deep extension into the eustachian tube, the carotid canal, the unresectable fixed nodal mass, the mediastinal structure, prevertebral fascia or cervical vertebrae, and subdermal metastasis or any systemic distant metastasis is the signs of the inoperability for maxillary sinus lesions. So coming to this is the natural progress of any upper alveolus lesion, which starts with only the loosening of the teeth and it can go on. So you may see the tip of the iceberg. So that's how you require an investigation and evaluation. I'm not going to go into the details of that, how you will evaluate the maxillary sinus and how you're going to see on the CT scan and all that. But CT, MRI and PET scan, you can do it to evaluate this patient. Let's come to the maxillary defects. I thought we will concentrate on this, some different aspect of looking at these defects. So if you look at the any kind of a classification maxillary sinus, this is one paper which gives the acronym DOC criteria. That means dental status, oroantral nasal communication status, contiguous structures involvements, superior inferior extension, anterior posterior extension, and a medial lateral extension. So these are the criteria. On these criteria, how the classification has been based on, whether they have mentioned about the presence of teeth, whether they have looked at the oroantral fistula, whether they looked at any resection of any important structures like a orbit or zygoma, pterygoid plate, lip, cheek, like that, or a superior and inferior extent of the lesion, like which level it is going, antero-posterior, that is where it is going, in which direction, and the medial and the lateral, whether it is a unilateral or a bilateral defect. So this is the classification. This should be an ideal classification where all these criterias are met. But there is no single classification which has described accurately the maxillectomy defects, and that could satisfy both surgical and prosthodontic need. So what is the most popular classification what we follow is the Brown's classification. That is, first initially it came with the initial 4 criteria, that is in 2000, and then there was a revised one in 2010 where another 2, that is the 5th and the 6th classification for the vertical component has been added up. So it involves the vertical component, which is the basically based on the aesthetic and the orbital support. One is without any orocutaneous fistula. The second one is without the orbital surgery with maxillectomy. The third one is orbital plate resection. Fourth one is orbit is included with maxillectomy. The other 2 defects are added later, that is orbitomaxillary defect without a palatal defect, and the other one is called as the 6th one is a nasomaxillary defect. So coming to this is the vertical component of it. The other 4 are basically the palatal defect. These are the horizontal defect, which are functional consequences, and the dental, masticatory, and articulatory points are very important when you have to document about the horizontal component. So you have only palatal defect, less than a half unilateral palate is involved, or a less than a half bilateral but transverse anteriorly, and more than a half palate is involved. So this is the classification which is very popular and what we follow. But apart from that, there are many other classifications. This is the MSKCC classification, which was way back in 99, where they have considered the 6th wall of the maxilla, the top one, the other 4, and the top and the bottom. So the top one is the orbital plate, and this is the palate. So if you have different types, so it is divided into type 1, 2, 3, and 4. The type 1 is only 1 or 2 valves of the maxilla and preserving the palate. Then the subtotal maxillectomy, that is the lower 5 are taken out and preservation of the orbital floor. The third type is basically total maxillectomy, where all 6 valves wall of the orbit are preserved and exenteration is added. So it is divided into 3A and 3B. And fourth one is orbitomaxillary, that is the orbital plus upper 5 valve and the preservation of the palate. So this classification basically gives the reconstruction options. So in the limited ones, they consider the FRAF and or a bone graft. In the subtotal type, they again consider the osteocutaneous free flap. In a total palate, total third defect, that is the 3A and 3B, what they consider is the bone graft and the rectus abdominis myocutaneous free flap or a temporalis pedicle flap. Or a larger defect, they consider the skin island rectus abdominis free flap. So this was in way back, but it does not mention about the rehabilitation using the obturators, and even the composite defects are not classified by this classification. So there are lots of fallacy how to use this, and this was an old classification and old guidelines to use the flaps. This is the another one, which is the Devin O'Kay's classification, where the type 1 is just a palatal defect. The type 1B is the premaxilla or alveolar process to the canines. Then type 2 is the less than 50%, type 3 is more than 50%, and then subclass into a orbital floor, that is by F, and Z, that is for the zygoma. So this is also a very popular classification among the MaxFax people, and it is very popular because they take into consideration the canines. The canines are the important tooth, if I can say, which is the important for the obturator stability. So it is the pivotal point where if you have both the canines, the stability of the obturator is good and the patient rehabilitation is also good. So you require at least one canine so to have a good stability. So as I said, so if you have a O'Kay's class defects type, that is class 1, then you can do a soft tissue reconstruction or a prosthetic obturator. In class 2, depending on the defect, you can use a prosthesis or you can use a vascularized bone containing free flap. And in class 3, usually the vascularized bone containing free flaps are preferred because you can give a orbital support also to the patient. Coming to the next one, the mid-facial reconstruction algorithms. Here again, if you have to remember that what should be the criteria, you should know what is the defect, you should know the dentition has been considered or no, and whether it is a soft tissue flap or no, the orbital exenteration present and absent, and depending on that, you will do a soft tissue flap or a vascularized bone flap, or you will use a bone graft versus the vascularized flap for the patient. This is the another classification and the guidelines where they have used both the Browns and the Corderos classification, and they have given the options available with the free flap and various types of the reconstruction options for the defect. You can also use an obturator, that's what they have written, and it's a very lengthy kind of a defect and the necessity. But this is a thing you can always do as we modify our technique about the free flap. I think we can have more and more option about what we can use it, but the fibula is going to remain as a mainstay of a treatment for the reconstruction for these patients. This is the another classification or algorithm what Dr. Iyer from India has given, and it is a very useful classification, the algorithm what they have given, that maxillary defect as you divide into different classes. So in a early class, that is a class 1, you don't require a reconstruction. You can do only a soft tissue reconstruction by a palate or a FRAF. If you have a viable dentition, you can use an obturator, or a free flap. But if you don't have a dentition, then the fibula is used with osteocutaneous flap. If you have a orbital floor support is required, then you require something called as double barrel fibula, or you can use with the viable dentition, you can use a fibula osteocutaneous flap or a flap also along with the soft tissue or a obturator. In a class 4, you need to have, depends on the patient medical condition and the aggressiveness of a disease, you may do only a soft tissue flap, or you may use something called as a DLA, internal oblique for the upper part of the and with the flap. So you can do all the combination with the double flap also for this patient. So this is the flap what they have used, free fibula, the tensor fascial lata for the support of the orbit, and the iliac crest flap or a rectus abdominis only the soft tissue flap, or a tensor fascial lata, iliac crest, internal oblique flap, that is TLF, TFL, ICLO with the dual anastomosis done for this step, for this flap. That's all. And it's a very nice paper written by Dr. Iyer, where you can actually see how much hard work is done to actually give a contour to the facial contour, to give the bone for the rehab, for the dental rehab for this patient, and the orbital support to have a good vision to avoid diplopia and the sagging. So if you see this paper by Bindra, where they have seen the all the classification, and they looked at the dental status, oroantral communication, the structures resected, the superior inferior extent, anteroposterior extent, and the medial and the lateral extent. So if you see Brown's classification actually ticks all the requirement criteria except for the dental status. But the OK is mainly popular because of the dental status has been added up. However, it does not look into the superior and inferior extent. The MSKCC data, the classification again looked at most of the points, but not looked at the dental status. They are not looked at the medial lateral extension of the defects. So it's a very, if you compare, none of the classification fulfill all the things, but there is a permutation and combination, there is a overlap. But Brown's classification, most of the time, if you document, that will be good to know your defects. So what are the goals of the reconstructions? The goals of the reconstruction are oronasal separation, that is surgical obturator, you can use it if there is a small defect. If there is a cranionasal separation required, then you may use a pericranial flap, the temporalis flap muscle, pericranium, fascia lata, or a microvascular free flap over the dura. The eye and the cheek support, you require a well vascularized bone flaps. For dental restoration, you require dentures and osseointegrated implants. Restoration of the facial defect, you may require local flaps, regional or free flaps, and a prosthetic restoration. And the most important thing in all this reconstruction is the prevention of the trismus. You may require a jaw opening exercises and maybe a coronadectomy intraoperatively to avoid trismus for this patient. And you need to calculate this patient and the kind of skin paddle, so that you take it into consideration the post-op adjuvant treatment for this patient when you're doing the reconstruction, and give all timely exercises to this patient. So take home message is it is very essential to separate the upper alveolus lesion from the maxillary lesions. They differ in many ways from the lower alveolus cancer, because lower alveolus cancer is a good prognosis versus the maxillary cancers, the upper alveolus cancer. The prognosis is good with the good surgical margin and with adjuvant treatment, as has been shown in the Rao's paper from Tata Hospital. And we need to classify maxillary defects better, maybe the Brown's classification or maybe the combination of OKs with Brown's, so that we can use it in our practice. And follow the appropriate and the best reconstructive plan for your patient with your plastic team. And the dental rehabilitation followed by that will be the key to give the best result to your patient. Thank you very much.
Thank you, ma'am, for sharing your expertise, and your talk was truly informative. And for anybody who has missed this lecture, can watch it on our channel, YouTube channel, that is Mahamana Head and Neck Oncology. So now we'll proceed on to our case discussion. And ma'am, I would request you to also join as an examiner. And today's case discussion will be on carcinoma oral cavity, and it will be presented by Dr. Arshad Ali from Kidwai Memorial Institute of Oncology, Bangalore. And our examiners for today are Dr. Bipin Burgess. He is Additional Professor, Department of Head and Neck Oncology, RCC Trivandrum. Welcome, sir. And Dr. Riddhi Sood, she is Assistant Professor, Department of Head and Neck Oncology, Kidwai Memorial Institute of Oncology, Bangalore. Welcome, ma'am. And Dr. Dushyant Mandlik, he is a Senior Consultant, Head and Neck Oncosurgeon from HCG Asta Cancer Care Center, Ahmedabad. Welcome, sir.
Thank you.
Arshad, you can share your screen.
I'll start with the case presentation. Good evening, everyone. The case I am presenting is of a 70-year-old male. He is a resident of Tumkur and a cab driver by occupation. He is retired now. He presented with the complaints of non-healing ulcer over the left upper jaw since 3 months. On further eliciting the history, it was seen that the patient was fine 3 months back when he noticed loosening of the tooth on the left upper jaw, and then subsequent extraction of the last 2 left upper teeth. The socket which developed after the removal did not heal and developed into a non-healing ulcer, which was initially small in size 3 months back, which around the size of 1 into 1 centimeter, and it is progressively increasing to attain the present size. The ulcer was associated with burning sensation on taking spicy food, and it was relieved on medication. Other than the intake of spicy food, there was no particularly pain over the ulcer. Then on further taking history, it was seen that there is history of loosening of the adjacent tooth present. There was no history of cheek swelling or loss of sensation over the cheek. There was no history of watering from the eyes, diplopia or decreased vision. So there was no history of nasal blockage, bleeding from the nose or any headache. There was no history of decreased mouth opening or earache. Yes, hello? Yes, ma'am? Should I continue, ma'am? Hello?
Yes, please continue.
Yeah, fine. There is no history of any neck swelling. There was no history of weight loss, and no history of cough or blood-tinged sputum. There were no comorbidities present, and he did not have any other major surgeries in the past. On taking further personal history, it was seen that he consumes a mixed diet. The patient consumed tobacco leaves along with betel nut 4 to 5 times a day for the last 40 to 45 years. He had stopped taking just before the appearance of the symptoms. Then he takes alcohol occasionally, and there is no significant family history. On summarizing, I'll summarize the history. So this is a 70-year-old gentleman with no comorbidities and history of tobacco and betel nut consumption, presenting with a non-healing ulcer over the left upper alveolus with loose adjacent tooth after dental extraction since 3 months. Should I continue?
Hello.
Arshad, Dr. Riddhi.
Yes, ma'am.
Arshad, please go ahead.
Fine. On general examination, the patient, hello? The performance score is ECOG-1. The patient is conscious, cooperative, and averagely built and nourished. The vitals are stable, and there is no pallor icterus cyanosis.
Arshad, before the general examination,
Yes, ma'am.
can you elaborate with your negative history? Where are you expecting the disease extension, and what is the location of the disease, and probable what is going on in your mind about diagnosis?
Yes, ma'am. So, ma'am, the patient has presented to us with a non-healing ulcer since 3 months. And before 3 months, that is before the starting of his symptoms, he had a history of dental extraction. So, in my opinion, the pathology might have started at that time and it presented with the loosening of teeth. And when the tooth sockets were extracted, that time maybe the pathology would be in the tooth socket, which was not clearly visible at that time. But after that, the socket which developed did not heal. So I am considering it to be a some pathology which is arising from the left upper alveolus area. And now that the lesion has increased in size, it's a lesion of about 5 into 4 centimeters. So I am suspecting it to be a upper alveolar lesion with and there is loosening of tooth also. On the other finding, that is that there is no history of swelling over the. So as per my history, I am considering it to be a some kind of a malignant lesion for now. And so I want to know the extension of that lesion, or any other significant factors, any other factors that may be associated.
Where all extension you are ascertaining with your
Ma'am,
negative history?
Yes, ma'am. Ma'am, anteriorly, I am thinking if it is a malignant lesion, so anteriorly it will be coming towards the cheek area. So there will be some sensation loss over the cheek, or there might be a cheek swelling. So those history I have taken. Then if it is a superior extension, then the involvement of the maxillary sinus, the nasolacrimal ducts, and if further superior, then there might be some eye symptoms also. So I've taken the history of eyes, diplopia, and decreased vision. Superiorly, still the nasal, it can involve the nasal cavity and the maxillary sinus, and maybe posteromedially to the skull base also. So I have taken the history of nasal blockage, bleeding, and headache. And mouth opening, because it is the lesion is in the palate, and adjacent area inferiorly might involve the pillars or the RMT. So whether the mouth opening is present or not. Earache related to the refertoptalgia if it is involving the anterior pillars, that area. Then considering to be a, in my mind, I am thinking of it to be a malignant lesion. So I am taking history of any neck swelling is there or not. And since it is there for a few months, that is 3 to 4 months, the last history as a just part of completion I have taken for weight loss, and whether any other distant involvement or distant metastasis is there or not. So the history of tough and blunt is sputum.
All right, go ahead.
Yes, ma'am.
Can I ask a question?
Yes, ma'am.
So I wanted to know, this patient had a tooth extraction, right?
Yes, ma'am.
So who advised the tooth extraction, and what is your opinion regarding a tooth extraction in a oral cavity cancer, or in this particular case, and how it affects the patient?
Ma'am, the patient, he has all here, he had all the dentition intact. He is 70 years old. That means his dental hygiene is fairly good. So, and he had a loosening of tooth at the upper alveolus. So it was moving too much. So that is why he himself went to the dental surgeon to get it extracted. But at that time, there was no obvious.
Is the correct thing to do it, or you feel that if anyone present like this, it should be extracted? What happens if you extract the tooth versus you don't extract the tooth? What needs to be, what should be the suspicion, and what should be the things so that you can help the patient? Do you think it is correct to extract or no?
Ma'am, the tooth were loosening. So as it is, after few days, it might have fallen by itself also. And if we are extracting, there is a high chance that we are giving it a pathway for it to go further inside. Hello?
So I feel you should not be extracting the tooth
Yes, ma'am.
also. what you require a careful examination of this patient in a good light, because the maxillary areas, the molar areas, you may not be able to see it in your OPD. You may use an endoscope if he has got a mouth opening degree, and you
Yes.
see the lesion and you take a biopsy if you have a high suspicion. Okay, and the next thing what you may have to do is maybe you require a cross-sectional images before you take a decision about a extraction of these teeth, because once you open up whenever you do a extraction of a tooth, the socket is open and there is a free flow of the tumor from the upper alveolus into the maxilla, and then so on and so forth, superiorly or laterally and all that. So you make that disease very, very advanced just by removing that tooth. I know in lower alveolus, so many times the tooth are very loose and all that. We are not removing anybody's tooth when we are doing a surgery for a lower alveolus and all that. Same applies to the upper alveolus also. So you have to be careful, and there should be high suspicion for the malignancy, and that's what you have to do it for this patient also. So I will say you should not be extracting the tooth unless you are very sure that it is you are dealing with the only a dental pathology, then only you will extract the tooth. Otherwise you should not be extracting the tooth.
Yes.
Other people agree with me? I don't know, Dr. Riddhi and Dr. Dushyant.
Anuja, I
Yes.
totally agree with you. And I think apart from this exam, I think it's a take-home message for all consultants and all the dental practitioners too, that beware of removing a tooth in a gentleman when there is a high suspicion of a malignancy. So I think point is well made.
You can go ahead. I think I finished with my question.
Then on local examination of the oral cavity on inspection, the mouth opening is adequate. The patient has good dental hygiene. There are tobacco stained teeth present. Coming to the dentition, on the right upper alveolus, there are from the medial incisor to the first molar, the tooth are present. On the left upper side, only 1 to 5 teeth are present, and the last 2 dental were extracted, and the last 5th one is having a loose tooth. Ma'am, can we cannot to point. Is it visible, ma'am? The pointer is visible?
Yes, it is.
So this tooth, he was having history of loosening of this tooth, and the last 2 tooth were extracted. Then the dentition in the lower alveolus, 1 to 7, the last molar was absent, and in the left side, the 1 to 6, that is the last 2 molars were absent. On seeing the lesion, it was a slough-covered ulceroproliferative lesion, around 5 into 4 centimeters in the left upper alveolus, extending to the hard palate medially, almost reaching till the midline. Then involving the upper GBS and the upper alveolus, and crossing onto the gingivobuccal sulcus on the left upper side laterally, adjacent to the premolar. That is the first and second premolar. Then inferiorly, it was reaching till the soft palate. It was just at the junction of the soft palate and the hard palate, and just abutting the RMT laterally. And anteriorly, it was 2 centimeter from the left upper incisor. The rest of the other oral subsides, that is the lip, tongue, the other side of the right side of the palate, the buccal mucosa, even the adjacent side of the buccal mucosa was normal. And on oropharynx, the visible part of the oropharynx was also normal. On palpation of the oral cavity of the lesion, the inspectory findings were confirmed. The lesion was not tender and does not bleed on touch. It involved the left upper GBS adjacent to the premolars, and the buccal mucosa was free. And skin over the cheek is normal with normal sensation. And on palpation also, the tongue, floor of mouth, and even the oropharyngeal part, the base tongue on palpation were normal. On the evaluating the nasal cavity, anterior rhinoscopy, there was slight DNS to the right side. and the rest of the anterior anoscopy findings were normal. The ocular involvement, the ocular evaluation, which included the examination of the orbit and the mobility of the eyeball, all were normal. Even the vision was normal. And diagnostic nasal endoscopy and video laryngoscopy both were normal.
What is NAD in NAD means?
Yes, ma'am. Ma'am, sorry, ma'am, no abnormality detected. Sorry, ma'am. I just
Abnormality. Okay.
I'll continue further, ma'am. The neck. On examining the neck, there was no scars, dilated veins, or sinuses, and there were no swellings noted. This is the right and the left profile view of the neck. On palpation, on examination, there were no swelling seen, but on palpation, there were multiple small nodes around less than 1 centimeter, which was mobile and not apparent to be significant. And the overlying skin were normal, and no other swellings were palpated in the neck. Then systemic examination were normal. The cardiovascular system and the respiratory system both were normal. Hello? Should I? Should I continue further?
Yeah, please continue.
So I'm summarizing.
Continue, Arshad.
Yes, sir.
Yeah.
So this is a performance score ECOG-1, 70 years old male with no comorbidities. He is a consumer of tobacco with betel nut, and he presented with a painless, progressive, non-healing ulcer over the left upper alveolus with adjacent loose tooth in 3 months and no nasal or ocular symptoms. So looking at the lesion and the examination findings, I am considering to be a malignant lesion of the left upper alveolus. And tentative staging, the clinical staging for now, I am putting it as CT4A-N0.
Do you have a differential diagnosis for this?
Sir, it is a slough-covered ulceroproliferative growth, and it is matching with the history of the dental extraction and the development of the lesion, and within 3 months, the progression to a very big size. So I am considering to a malignant lesion only, sir.
So, Arshad,
Yes, sir.
I think we are through with history and examination,
Yes, sir.
but I would like to ask you about the histories the patient had. He had a history of tobacco, right?
Yes.
And mostly in the chewing form, I think, right?
Yes, sir.
Was he having history of smoking tobacco, or it
No,
was
no,
smokeless tobacco only?
Smokeless tobacco only, sir.
Smokeless tobacco, and he had history of alcohol also, I think, right?
Yes, sir. Occasional alcohol intake. It was.
Occasional alcohol, right?
Yes, sir.
Right. So, what are your views about his tobacco history and alcohol history, and how the both will affect, how the single will affect, and is there any correlation between having multiple substances which are abusive or not?
Yes, sir. Sir, smokeless tobacco, there are many carcinogens present in the smokeless tobacco. For example, like in the smokeless tobacco, some tobacco-specific nitrosamines like NNN, that is nitroso-nornicotine, then NAB, NAT. These are the carcinogens which are mainly involved in the development of the carcinoma in the oral cavity. And the occasional alcohol intake, actually alcohol in itself is not a carcinogen, but it increases the absorbability of the carcinogens inside the oral cavity. So in combination with alcohol and with the other factors like deficiency of vitamins, especially the B1 and B2 vitamins deficiency, and the alcohol products like the acetaldehyde and all, those are the factors that will cause increased absorption of the carcinogenic substances in the tobacco. The site as such is not clearly matching with the habit that he is having, because in Indian scenario, majority of the cancers are seen in the left gingivo-buccal complex. But looking at the oral cavity subsite, looking at the oral cavity as a whole, there can be a chance of development of cancer in the upper alveolus also. Hello?
Yeah. And Arshad, many of the patients take lime with tobacco.
Yes, sir.
So any significance of using lime, why they take lime with the tobacco and how it affects carcinogenesis?
Sir, the lime, it's an alkaloid which causes abrasion of the mucosa of the buccal cavity or the oral cavity as a whole. So that also increases the absorption of the carcinogen more as compared to a patient, as to a person who is not taking lime. So it increases the absorbability, also the effect of the nicotine is increased. So the patient have more kick as compared to a patient not taking lime. The
Right.
absorption is
Arshad, there is a question in the chat box about did you ask specifically for reverse smoking?
yes, ma'am. I asked about the reverse smoking.
How is it
First of all,
relevant in?
First of all, he did not have any history of reverse smoking or smoking as a whole. He was mainly a tobacco chewer only, and the malignancies of the hard palate is seen more commonly in reverse smokers, which is practiced in some rural parts of India, where the burnt end of the BD, especially the reverse smoking is generally done with BD, and the person keep the BD, the burnt end inside the mouth. So, in addition to these carcinogenic substances getting absorbed, there is the factor of heat also which comes into play, and the mucosa over the hard palate is adherently attached to the bone. So in that area, the effect of the reverse smoking is more. So the carcinogenic deposit over there is more. So it mainly predisposes to the development of carcinomas in hard palate.
So
Yes,
there
sir.
is a question in the chat box again. How do you differentiate it from a malignancy per se of maxilla? Because the loosening of teeth
Yes, sir.
came in later. That's one of the questions in the chat box is that. How do you answer that?
Sir, actually, just on clinical examination, we can if the lesion has started in the maxilla, the nasal symptoms might come before the development of the ulcer and all. So that might be one point. Then in our scenario, the lesion, the pathology started with the extraction of tooth. So I am thinking the main pathology would be in the upper alveolus as compared to a palatal pathology or a
No,
maxillary.
but the reason why the question was put was the initial symptom was loosening of the teeth and not
Yes.
the ulcer per se. So loosening of teeth can be a presentation when it involves the infrastructure of the maxilla.
Yes, sir.
And when the disease, how do you differentiate between a maxilla, CA maxilla and a carcinoma of the upper alveolus by its appearance or by its history? You said that there would be nasal symptoms if it's a pure carcinoma of the maxilla. And suppose suppose this was the CA maxilla involving the floor and it presented as loosening of teeth and finally it ulcerated when the extraction was done.
Yes, sir.
Then what would have been the eliciting feature as to its origin from the maxilla?
Sir, if it is coming from the maxilla to the alveolus, then initially it would have been presented with the submucosal bulge in the palatal, in the lateral part of the
So
tuberosity.
that is what would be the
submucosal bulge would have.
distinguishing feature, is it?
Yes, ma'am. Yes, sir. Sorry.
So you need to say patient did not give any history of any kind of
No,
swelling inside the.
no, sir. No, sir.
Or,
Okay, yeah. Fine, sir.
okay.
Arshad, what will you do
With
next?
this question,
Further, I will like to I have to prove the diagnosis by taking a biopsy from the lesion to see what I am dealing with exactly. So I will be taking an incisional biopsy from the representative area. That is the area which is at the. Hello, am I audible?
Yes, you are audible, Arshad. Go.
Yeah, I will like to take a biopsy from the representative area from the lesion at the edge of the lesion, and I want to get the histopathological report to know what I am exactly dealing with.
Yes, Arshad. How you will proceed to take the histopathology report? What kind of biopsy? How you will do it?
Sir, I will take an incisional wedge biopsy with a part of the ulcer and part of the normal mucosa, and with the apex of the wedge being at the normal side, so as to get a proper representative tissue for diagnosis.
Will you be able to have the same tissue and for diagnosis by doing a punch biopsy?
Sir, the lesion that I'm dealing with is having a lot of slough covering the main ulcer. So if I try to take the punch biopsy, there is a high chance that representative specimens biopsy in that case. So I would rather take an incisional wedge biopsy as opposed to a punch biopsy.
In any case, you will do any scrap cytology or something like that?
Again, sir, the same thing. With the scrape cytology also, the chances of me getting slough is more in this case. As we can see in the lesion, the whole ulcer is covered with slough. So again, the same thing might happen, and I may have to take multiple biopsies in that case. And the incisional biopsy will be gold standard. I would be getting a good representation. Yes, sir.
You are seeing that the slough whitish thing, if the entire lesion is covered,
Yes, sir. Yes, sir.
you're not able to take wedge and or to even wedge, maybe have a stuff on it. In that situation, how do you take a biopsy? What is recommended?
Yes.
I think that it's only one area you can see flesh in my area, rest of things is covered white tissue. Hyperkeratotic, okay.
Sir, incisional
In
biopsy from the
If, for example, trismus is there, you can see white tissue, that's all. But CT scan imaging enhanced lesion, but one and retracting, you are seeing
Yes, sir.
only white stuff. How do you take a biopsy? What is suggested in that situation?
Yes,
What
sir.
you supposed to do?
Deep biopsy in that case, I will infiltrate it and take a deep.
You have to
yeah. So that
In
dig
that case, sir, I will
dig
take a
dig. How you do shear stomach when there's slough? In a deeper biopsy, you dig out the whatever slough, then go for a deeper granulation or whatever fleshy tissue. Till that time, you have to take out all the stuff. Okay, then you can't do incision biopsy. In that case situation, you have to go take a deep biopsy.
Yes, sir.
Okay.
So that brings us to a question which was there already asked, whether you will do the imaging first or the biopsy. So which is the sequence actually for any case?
Sir, for this case, as it is a big, fairly large lesion, so the staging is high, and imaging or biopsy first will not change my management in this case, because it is already a T4A disease. So even if I take a CT scan first or biopsy first, it will not matter, because the inflammation which comes in response to the biopsy will not upstage my disease. In small cases, in small lesions like T1 lesions, where my biopsy will change the management, especially when a T2 lesion, when I'm taking a biopsy and it is getting upstaged to a T3 disease, that time, because my management is changing, that can hold true. But in this case, either is fine before
No,
biopsy.
any case you need to have a imaging, right?
Yes, sir.
So only question is when you have,
First.
which one will you do first?
Sir, in small,
And of course, you just have to defend whatever you do. That's all. I just asked the question and it was there in the chat box also.
yes, sir. Yes, sir.
So in this case, you prefer to do the biopsy first.
Yes, sir.
For the reason which you said, you need to get the tissue diagnosis, and then why do you want to make imaging next to biopsy?
Sir, because in this case, the biopsy will take few days for it to get processed and come. In the meanwhile,
Yeah.
I can further evaluate the patient with cross-sectional imaging and all. So that 3-4 days time I will get extra for the management, for the investigation, this part, the CT scan and the cross-sectional imaging.
Yeah, the simple answer is you want the imaging as close to your management as possible.
Yes.
Because by the time you get the date and the patient comes for surgery, you want to get the latest
Yes, sir.
situation when the image is with you, right?
Yes, sir.
Arshad, you have staged this as a T4 tumor.
Yes, sir.
What are your rationale behind staging it? And
Sir, one thing, the dimensions of the lesion is at least 5 centimeters, 4 to 5 centimeters. So it is at least a T3 lesion, but with the involvement of the loosening of the tooth. And as we can see, the lesion is crossing the alveolar mucosa and crossing onto the GBS, the left upper GBS. So I am thinking there is a high chance that the bone involvement will be there. So that is why I am staging it as T, and there is loosening of tooth also. So, and the lesion, it started with the loosening of tooth also. So I am
so
considering.
will you like to put it T3/T4 depending upon your radiology, or upfront T4 only?
Sir, as per
clinical. Because your clinical staging includes your clinical examination as well as your radiology.
Yes, sir. I would like to confirm my clinical findings on radiology, but yeah, for now I can keep it as T3/T4A for now. But I will be more in favor of. Yeah. Yes, sir.
No, did you describe in sublabial palpation while you were presenting the case?
Yes, sir.
Or if I missed,
on palpation,
what was the finding?
Sir,
Yeah.
on the sublabial evaluation, there was no cheek swelling. I have mentioned that, and even in the pre-maxillar area, nothing was palpable, or there was no bulge or anything in that area.
But then the only reason why you say it is T4 is because there is a ulcer and there was no teeth,
yes,
is it?
Yes, sir.
Yeah. So I was asking the question,
Yes,
would you consider anything? Suppose your biopsies were coming as negative repeatedly, in spite of taking multiple punch biopsy or incisional biopsy and things like that. Will you think, for the same reason, will you think that there could be some other possibility also for this patient? Other than the malignancy, which is squamous cell carcinoma?
Sir, if the multiple times biopsy is coming negative, there is a chance, but it will not, there is a chance that it might be a
Fungal.
some early carcinoma, like lesion or a leukemia. No.
You have to think in terms of something else, because your biopsy is pointing to something else.
Aspergillus fumigatus can have such a bone eroding lesion, but the presentation will be different.
What are they?
there will be some immunocompromisation will be there in the patient. Then there might be some pathology in the nasal cavity. There will be some pathology in the maxillary sinus. So the fullness of the maxillary sinus, the cheek area, all that things will be there. There will be staining. The nasal secretions will be there, and
Destructive lesions
bone
of
destruction.
the heart palate, other than malignancy, what are they?
Multicentric NK T cell lymphomas can present with
Yes.
in the palate lesion, but it will be more in the midline and involving the nasal this part also.
Okay.
Yeah. The lymphomas.
Yeah. That can be midline destructive lesions, among which your lymphoma could be one of those possibilities, which you mentioned. T cell lymphomas. Yeah. So how do you proceed further?
Sir, I will now like to do basic workup for this patient, hematological and biochemical workup for this patient for the general evaluation. Then I would then proceed on to do a cross-sectional imaging in the form of a contrast-enhanced CT scan of the paranasal sinuses, the neck, and the thorax. CT paranasal neck and thorax, and I would like to take a look at the extension of the disease in all the directions: anterior, posterior, lateral, medial, and superior, inferior. And I will just show the CT scan.
On thorax also to be included in your CT?
Yes, sir. The chances of distant metastasis in such a lesion is fairly low, around 5%. But still, I would like to go ahead with the CT thorax because we are doing it as a part of a routine here. And just there is the time taken for the CT acquisition for the thorax when we are doing PNS and neck, it just takes few minutes. And as a general protocol, only we are following it to take the thorax, especially in the T4 lesions, high stage lesions, high T staging. We are doing routinely for the CT thorax.
Okay. Besides looking into okay. And how do you? What are the things you are going to look? Thorax. You have given your explanation why you include the thorax.
Yes, sir. Sir, yeah. In the it's a T4A lesion, the chances of metastasis to neck is also high. That is around 26 to 35% almost. In different studies, they have quoted as 21 to 30% almost in T4A lesions of the upper alveolus. So I would like to include the neck also in this case in the CECT. And
what is the first echelon which
1A
you look for?
Hello, sir. Upper alveolus
yeah, 1A
will be 1B, 1A, and level 2, and posteriorly to the retropharyngeal lymph nodes.
That is when it's involving the maxilla.
Maxilla, yes, sir.
Right?
Yes, sir.
Yeah.
Yeah, I'll start the CT scan.
Okay.
Is it visible?
It is visible, Arshad.
So this is a contrast enhanced computed tomograph. Yes, ma'am. This is the contrast enhanced CT scan of the PNS and neck with 1.5 mm cuts, and I'm scrolling from superior to inferior. We can see superiorly. I'll just come on to the superior part of the lesion. So there is a heterogeneously enhancing lesion seen in the upper alveolus. Sorry, is my pointer available? Pointer is not. Okay. So So this I can see the heterogeneously enhancing soft tissue lesion seen in the upper alveolus in this part, superiorly involving the lower part of the maxilla, the inferior part of the maxilla, and almost reaching till the it is abutting the lateral pterygoid, the lateral pterygoid muscle over here. It is laterally it is extended to the upper GBS, this part. There is erosion of the inferior wall of the orbit anteriorly, anterolaterally, and posteriorly. Then inferiorly, it is extending to the palatal area. There is soft tissue density in the palatal area also. And inferiorly reaching up to the RMT, it is just stopping at the level of the RMT. There is involvement of the soft tissue, the junction of the hard palate. Some part of the anterior pillar, there is slight enhancement. Yes, sir. For the superior inferior extent, I would see the reformatted images, and on the bone cuts, I can. There is erosion of the on the bony cut. We can see the erosion of the inferior wall of the maxilla in this part, and the upper alveolus. The lesion seems to be epicentered in the upper alveolus only. I want to reformat these images into coronal sections to know the superior inferior extent of the lesion. Is it fine, sir?
Yes, Arshad. Will you like patient to do some maneuver while you are doing this CT
Yes, sir.
scan?
Yes, sir. While doing the CT scan, we ask the patient to blow his cheek,
Blow.
the cheek technique, so as to properly visualize the upper GBS area, the lower GBS area. So the subsides are clear.
It is very important in this lesion
Yes,
because
yes,
the upper left BA sulcus, you will like to delineate how it is,
yes, sir. Yes,
and
sir.
it is actually related to only palate or it's going to sulcus, right?
Yes, sir. Sir, I'll be reformatting it in coronal sections.
So what are the advantages of doing a puff cheek technique?
Sir, in the puff cheek technique, the vestibule of the oral cavity will be more obvious, and we will be able to see the upper and lower GBS area clearly.
Right.
Has it?
So that is what you missed when you did the clinical examination, right? You said you have done the sulcus examination, but still you could not appreciate a lesion. You could not appreciate anything on the
Yes, sir.
anterolateral surface of maxilla, right?
Yes, sir.
Yeah.
Sir, on the coronal section, we can see the lesion which is eroding the inferior wall of the maxilla. Arrow is visible, sir. Upper alveolus, it is involving the upper GBS in this part. Essentially the rest of the buccal mucosa is normal, and the lesion is extending to the left hard palate in this part, and it is almost reaching till the upper part of the RMT. There is no erosion of the palatal bone as such, and the nasal cavity and other areas are normal. As we can see, the inferior orbital, everything is normal, just the lower part of the maxilla, there is erosion, and the intrasinus minimal extension of the disease in the inferior part of the sinus is there. Posteriorly, it is reaching till the laterally to the pterygoid plates in this part. The lateral pterygoid muscle is just abutting.
Arshad,
Yes, sir.
how you will differentiate on a CT scan when the tumor is in maxilla or around maxilla, the intrasinus extension versus thickening of the sinus mucosa or inflammation or collection?
Sir, the collection will have a concavity. There will be a meniscus when the sinus secretions are present. The enhancement will be similar to the lesion, and there will be a break in the inferior sinus wall. Some bony erosion will be there for it to go inside the sinus. So in this case, as we can see, there is bony erosion, and then the same enhancement can be seen in this intrasinus area. This might be the area which is superior to that part, like this part. This is the differential, the heterogeneity is lost in this part. So this I'm considering to be a edematous mucosa mainly, but this part is almost similar to the enhancement of the lesion, the heterogeneous enhancement. So with that I can differentiate. But to better delineate the part, I would
You're not audible.
Arshad, we are not able to hear you.
Signal drop.
Hello,
Arshad?
Arshad? Are you there?
Arshad, can you hear us? You're not audible.
I think Arshad needs to connect with a better device or better internet.
Yes, I think he has logged out and will log in again. Okay, why don't we after this? We'll be leaving at 7.
Hello. Hello.
Yes, you can
Arshad,
Yes,
continue.
Arshad.
Really sorry for the connectivity, ma'am. Sorry. Now I'm audible, right?
we lost you
Yes,
in the
yes,
last
you're
part.
Sorry. Sir, I was telling about the mucosa, differentiating the mucosa with the secretions in the maxillary cavity.
So
So,
Arshad, I think
yes,
to
sir.
make a point, can you tell us where you will like to have an MRI in a maxillary
Sir,
tumor
I was
to
coming to
know
that
that?
only. Yes, sir. Sir, in cases like these where I'm confused, where I'm not getting exact point whether the area of enhancement is because of the mucus, because of the secretions, or because of the lesion, I would like to do an MRI in that case. The MRI having a better soft tissue delineation will be able to tell me about the secretions and differentiate it from the lesion, the extension in the mucosa, the extension in the lesion extension in the maxillary cavity. So with that, I will be able to differentiate what exactly is there in the maxillary sinus.
What
so
will be
which
other
one?
indications?
Yes.
What will be other indications where you will like to have an MRI?
Sir, in cases where the lesion is reaching till the orbit and I don't know whether the orbital involvement, the periosteal involvement, soft tissue involvement is there or not, in that case, I would like to take MRI complementary to the CT scan. And in cases of paranasal sinuses, these three areas in this such a case, I would be complementing it with MRI to get a better define the better soft tissue involvement in that case. And the cranial
Any-
extension.
Any point about
Hello.
any point about infratemporal fossa or neural involvement?
Yes, sir. The
Infratemporal
paraneural
fossa
spread I will
or
be able to see with the help of yes, sir. Infratemporal fossa, the pterygopalatine fossa, that area I would be able to delete with the help of MRI. The spread through the sphenopalatine
What are the
foramen.
images which you specifically look for within the MRI? What weighted images will help you in detecting all the features which you have described, including perineural invasion?
Yes, sir. Sir, for MRI, I will be taking T1 contrasted images, T1 plus C, to see the lesion, the involvement with the gadolinium in contrast. And that will be, with that, I will be able to see for the lesion, where the involvement of the lesion is. Then the diffusion weight, for the fat content, I would be taking the T2 weighted, T2 fat suppressed this thing, T2 fat suppressed study to see for the lesion and where this thing is. And for perineural spread, again, T2 fat suppressed images I would like to do to see for the perineural.
To differentiate between fluid, retain secretion, and the what do you
Yes,
use? Which one do you
so
take?
diffusion weight MRI I will be doing for that. So the diffusion weight images will be able to tell me with there is a diffusion weight, there is a specific coefficient AUC where we will be able to see the cellularity, the Brownian movement of the of the of whatever the lesion is there. So the Brownian movement will be more in case of a fluid as compared to sorry, ADC, not AUC, the ADC, my mistake. The apparent diffusion coefficient I would be able to see. So it is less in cases where the cellularity is more. So if the ADC is less than 8.8, then I am thinking that it is more of a cellular area, and if it is high, that it means it is more of a retained secretions. So that DWI will be helpful for differentiating those.
What are the uses of T2 images?
Yes, sir.
T2 weighted images. What does T2 weighted images tell you?
Sir, in T2 weighted images, the water will be the more content of the fluid will be appearing more whiter. So in those cases also, I will be able to see the more whiter the area is, the more secretions, chances of secretions is there.
That's what I was asking. The other one is
Sorry.
So that would have been your first answer, and then maybe elaborate on the diffusion weighted images also.
Sorry, sir.
After that, right?
Fine, sir.
Yeah.
Then I would I have seen the extent of the tumor in all the 4 directions. I want to see the part of the neck. For the neck, we can see that on the cross section, on the axial scan, there are multiple small nodes which are there in the left 1B area. Even in 1A area, few small nodes are there, but these are not looking to be significant. The size is less, and even the shape is not. They are longitudinal nodes. There are no nodes in the retropharyngeal area or any other levels of the neck. And CT thorax also is normal. The CT thorax, there is no nodules or any lesions in the chest, in the thorax, lungs. So is it fine?
Yeah, go ahead. So you have done, you have shown You have done both imagings, is it, in this
No,
case?
no, no, sir. I have only done the CCT neck and thorax, sir, for this case. Neck,
Okay.
PNS.
Right.
How will you manage this case, Arshad?
Sir, ma'am, sorry. Looking at the total, the clinical examination and the radiological findings, now I am able to stage the disease as T4A N0 M0, and I would like to tell the patient about the diagnosis and the extension of the disease. So, with the joint involvement of the patient party, I will be telling him about what we are dealing with. I will be telling him that it is a malignancy of the upper alveolus and it is a advanced disease, T4A, the stage is there. And I would like to discuss with him the management options. So our patient, he's a 70 years old male with no comorbidities and a good performance score, and he is having all the dentitions and all, fairly good dentition and fairly good oral hygiene. He is somewhat educated, so I will be taking the informed management plan with the patient. So I will tell him that the management will be curative intent, and we would like to offer him surgery in the form of, I would like to offer him a curative surgery. Hello?
What are the situations where you would also ask for an MRI?
Where there is involvement of the orbit, where there is involvement of the ITF, where there is involvement of the skull base, in those areas I will be asking for an additional MRI complementary to the CT scan. But in this case, the lesion is it's a low maxillary sinus involvement disease. So the MRI will not be giving me an additional information in this case, this particular case. So I think with I would be able to take my decisions based on the CECT alone, on the
Okay.
imaging.
So what next?
Sir, I will be planning. I will be telling the patient about the curative intent surgery in the form of infrastructure maxillectomy, and the maxillectomy will be not involving the orbital wall. There, the inferior wall of the inferior wall of the maxillary sinus will have to be removed, and there will be a communication between the oral cavity and the neck. Oh, sorry, oral cavity and the antrum and the nasal cavity. So I would like to discuss with him the management options. I will tell him about the management options that will be surgery is there, then the reconstruction plan, the various things that will be having after the surgery. There will be a through and through defect between the nasal cavity and
So what is your
and the oral
plan?
cavity,
Is it for
antrum and
to
oral cavity.
reconstruct or to rehabilitate?
So the plan will be both to reconstruct as well as to rehabilitate. The
What do you mean by that?
sir, first after the resection that I am planning, there will be an oronasal fistula. There will be loss of the nasolabial fold will be there. So all these areas I have to reconstruct along with a good.
Why would there be a loss of nasolabial fold?
Because the lesion is involving the palatal part also. So my management, the surgical extent will be almost half of the right side of the palate, along with some part of the contralateral palate will also be removed. And in addition to that, proper infrastructure maxillectomy with the posterior extent being the pterygoid, the posterior extent being the pterygoid plates, that also has to be removed. And there will be a hollow at the facial, the cheek depressed, the depression of that cheek will be there. And so
should be able to tell exactly how your postoperative appearance will be, and what are the issues that you're going to handle after the specimen is removed. So
yes, sir.
whether it is, I mean, whether your ultimate aim is just rehabilitation alone or reconstruction,
Sir,
complete reconstruction or rehabilitation plus reconstruction. So you have to have a definite plan which has to
yes,
be
sir.
explained to the patient, right? That's what I'm asking.
Yes, sir. So it will be
So, Arshad, what Dr. Bipin is telling you is that you need to counsel the patient on two fronts, or rather multiple fronts. One is oncological front,
yes, sir.
that how his cancer is going to behave
Yes, sir.
once you operate. Two is that the defect, right? How this defect is going to have A, cosmetic implications,
Yes, sir.
and B, functional implications. That is important for you also,
Yes, sir.
that you need to correct A, cosmetic correction, B, functional correction also, right?
Yes, sir.
Then you have to explain what are the modalities of A, rehabilitation, B, reconstruction, C, rehabilitation after reconstruction for this patient.
Yes, sir.
That includes your oronasal separation, A, B, dentition,
Yes, sir.
and C, the cosmesis.
Yes, sir.
So
Yes,
you have to address all the issues one by one and then help to make him a choice depending upon various factors, which
yes,
may include patient factor, which may include doctor factor, which may include the factors which your institutional protocol is,
yes, sir.
to decide on how to go about reconstruction or and rehabilitation.
Yes, sir. So first of all, this is a malignant lesion. So I will tell him that he will require infrastructure maxillectomy, in which the whole of the palate will be resected, and along with the some part of the inferior maxillary wall. So the main point I would be covering will be the oronasal, oronasal and the oroenteral fistula. So that has to be closed. I will explain to the patient this thing. The second thing will be the loss of the hollow will be there in the nasomaxillary groove. So the cosmesis I have to take care. Then the dentition I have to formulate after the surgery. I have to make sure that he have a good obturator or something that he will be able to have he with which he can chew. The dentition I have to see. Then the nasal regurgitation, if it will also be there, so that also has to be taken care of. And so all these things I will explain to him, and I can give him an option of the obturator, in which after the resection, I will be almost the half of the palate will be gone. So the opposite half I can use for the obturation. I will make a previously I will have his dental evaluation and nutritional assessment of and all the other things done for the fitness, and psychological evaluation also, because the loss of teeth and the loss of this thing will have a good impact on the patient's psyche. So psychological evaluation, nutrition, all this has to be taken care of. Then with the help of, I will tell him about the pros and cons of both the reconstruction, using a flap or using an obturator. So the with the respect to the obturator, the oronasal and oroenteral fistula to an extent will be covered. Afterwards, when the final process is after 3 or 6 months down the line, when he's getting developed, when the cavity is contracted and properly epithelialized and all, then we can consider that for the dentition also. We can use a final processes with dentition, with which he will be able to take care of the dentition also. Then the final obturator will help in the lifting of the nasolabial groove also. So that will take care of the cosmesis also and the regurgitation also. The another option that I can give him is a flap in the form of a
How do you think the nasal?
Yes,
Okay,
yes, sir.
please go ahead. Yeah, there was another question. You can just listen to that because I.
Fine. Yes.
Yeah.
Hmm.
So you nasolabial nasolabial groove.
Yes, sir.
Nasolabial fold.
Sorry, nasolabial.
And when you plan your surgery, do you make an exception for any reason?
Do I make a hello?
I think the
connection is losing in between. Pardon, sir.
So your approach to expose the tumor.
Yes. For the approach, sir, I will be using a Weber-Ferguson incision for this case because the lateral extent I will not be able to reach with just in a per oral incision. So I will be using the approach will be Weber-Ferguson, and I would retract the flaps and then do the resection with the inferior maxillectomy and just at the level or below the level of the exit of the infraorbital nerve, I will be taking the uppercuts, depending upon the lesion also, where I find the.
How do you describe the Weber-Ferguson? Can you describe the incision?
So Weber-Ferguson incision, we take a incision at
Yeah.
the bottom of the lip, then come inside and join it with the sublabial incision from the incisor to the maxillary tuberosity. It has an external incision which comes from the medial canthus of the eye along the nasolabial groove and along the philtrum of the nose, and then curves around at the transphilomela, then parallel to the philtrum at the level of the philtrum, and both the incision is joined to raise the flap, the Weber-Ferguson flap on the flap on the lateral side, cheek flap, upper cheek flap laterally.
How much of exposure do you get with the Weber-Ferguson?
Sir, at least the lateral side, the maxillary tuberosity will.
How much of? You said it's to get your lateral exposure.
Yes.
That you have used.
So
with the Weber-Ferguson, you get a lateral extension, but in this case, extension was beyond.
Sir, I will try to see the excess with the help of a Weber-Ferguson incision, but if at all I am not getting proper
posterior wall of the maxilla,
posterior wall of the
into
I
the
will include the Dieffenbach extension, the subciliary 3 mm below the subciliary line. I will include the Dieffenbach extension on the lateral. Hello?
No, you said you're going to start with the Weber-Ferguson and then look at the fact that you're getting enough exposure or not, and then deciding on what to do next, right? Is there another option of doing a better planning and using some other alternative?
Sir, the other alternative
No,
will be sublabial.
We are not hearing you completely. That's the main issue.
Sorry, really sorry for this. Sublabial extension I can use.
Yeah,
sir,
so what I was asking was any alternative to
struggle
Weber-Ferguson in this particular.
Sir, I will not be. I can use the per oral sublabial approach, but I am not sure of the superior extent of the disease, and also the lateral, the posterior wall and all I have to reset. So I am not very sure of whether I will get a good exposure in that area, and I might compromise on the margins. So
I do agree that Weber-Ferguson is better than per oral. That much I can agree. But does that serve the entire purpose of getting an adequate margin and adequate resection in this particular case, or is there an option other than that where your exposure is just adequate and you don't have to, you can even do away with the Weber-Ferguson? Is there any other approaches that you can think about in case of infrastructure, maxilla involvement or infrastructure, hard palate? It's a hard palate lesion basically, not a maxilla per se, right?
Yes,
so you have any other option?
Mandatory.
And that too, it is going behind.
The mandibulic, we can think of a mandibulic, but it will be more morbid for the.
Cosmetically better than Weber-Ferguson, no?
Cosmetically, it will be better, sir, but
exactly what we are trying to ask you. I mean, you can always defend your approach, but then you just have to say that, because in this case you said it is morbid. The mandibulotomy is morbid. That's what you said, no? So how do you bring down the morbidity of mandibulotomy. You can do a nice mandibulotomy
Step
and
ladder,
do a
Step mandibulotomy.
step ladder mandibulotomy we can do at the paramedian mandible area, and then we can bring down that.
If the patient insists, I don't want any scar on the nose and lips, it's more ugly.
Yes, sir. Then
If you
and
want
swing,
some
no?
other approach,
yes,
It
sir.
gives a
do you have it?
beautiful exposure of the
Yes, sir.
So, mandibular to midline split is better, no? Cosmetically, it's better than the
Then the
Weber Ferguson. Okay.
Yes, sir.
you can combine it with the neck, with the lip split can be
Split with the neck incision we can do. And also I would
and that way you get an advantage.
yes, sir. I will be also including the neck dissection with my resection part. At least I will be clearing level 1A to 3. 1A, 1B, 2 and 3.
Yeah, so that is another advantage of
yes, sir, yes,
this
sir.
particular incision and the approach.
I will address the neck also for this patient. And post-operatively, after the histopathology, the plan of the adjuvant RT will be taken. This patient will at least require an adjuvant RT in the form of IM RT most probably. And other than that, that would be the final. Sorry. Some beats. Hello?
Yeah, we can hear you.
Audible?
We'll conclude in another 5 minutes.
You're using the mobile, is it? That's why. Phone call had come.
We'll conclude in another 5 minutes. So last few questions that can be asked.
So Naina,
The
I
point
think
where
I'm
we have done the resection and
yes, ma'am.
sorry, I think I'm done from my side. That's all.
Okay. Okay. Any more questions from
there was
anybody?
a question of what is the ideal reconstruction that you will choose for this case.
Sir, ideal reconstruction.
So there is no ideal reconstruction actually, because depends upon what is your choice of reconstruction.
Sir, I would like from my side.
Wind up in 5 minutes. That's what we have been
sir,
told. The session was good. We are just trying to conclude.
Yes, sir. Sir, that would be the obturator, the infrastructure maxillectomy along with neck dissection using the Weber-Ferguson technique, and then the post-operative obturation, and after that, after 3 to 6 months of proper healing, proper dentition and the obturator with the dentition, I would like to go for this. Taking in mind that
exactly. So that is
sorry. Yes.
So when your approach is to do an obturation, you have to optimize your surgery also. That's why I was directing you all these questions. Like you have to do an optimal resection so that the defect is mainly confined to the hard palate and the rest of the defect is just that is required for the tumor. In which case you can do a good rehabilitation. You can have a good skin graft lined cavity, which can be very effectively managed with the obturator. That's the point I wanted you to say. And in this case, if you are very indiscriminate in your approach, then also the need for reconstruction will go up, and maybe you may have to bring in a more like kind of tissues from elsewhere. You may have to go for
yes, sir.
Just for that reason alone. So that's why I was directing you towards optimal resection, which is very important in these kind of situations.
Fine, sir. Thank you.
So how long will you expect your patient to survive this case once you have done a good job in terms of resection and then, whatever form of, reconstruction or functional rehabilitation?
Sir, I am expecting for
Can
this.
you hear me, or is it?
Yes, sir. I can hear you, sir. The 5-year survival for a T4 disease after maxillary of a left upper alveolar disease, I am expecting so 5-year survival more than 40%, around 40-45% I am expecting. So, and he
Right.
being a 70 plus 70-year-old male patient, I think it is an acceptable survival rate for a T4 lesion of the upper alveolus, around 40-45%.
Right. Yeah. So I think you have done quite well. You have answered most of the questions to the expectations of all of us. That's what I guess with the rest of us also. And there are no more questions. I think we're ready to wind up. And any more questions in the box can also be addressed.
Thank you, everyone. Thank you, all the examiners. It was a great discussion. Thank you, Dr. Arshad. You did well. So we'll meet again next time with a new topic and a new resident. And yeah, thank you.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank
Thank
you,
you.
Dr. Siddhartha, sir.
Thank you.